بسم الله. اليوم إن شاء الله رح نشرح عن الليمفedema، بس رح نحكي الآن مقدمة. The lymphatic circulation belongs to the circulatory system. One way for the blood to leave the heart is through the arterial system, and we have two ways to return to the heart, through the venous and the lymphatic pathway. Once it has entered the first lymph capillaries or the initial lymph capillaries, this fluid is called lymph. Now the microcirculation. هلا احنا في عنا فرق ما بين blood circulation blood circulation lymph circulation. The lymph circulation, it has slow rhythm, low velocity and low pressure. The filtration that come out of the blood capillaries, it will go inside أو يعني it will be uptaken by the lymphatic system or the lymphatic capillaries. So وهاي الفلتريشن اللي بتطلع من blood capillaries are very important. هلا بنشوف ليه. If the lymphatic system did not recover the protein-rich fluid, the body will probably develop major systemic edema, protein loss, auto-intoxication, and die within 24 to 48 hours. Now, the lymphatic gradually increase in size. We have بنبلش ب أصغر إشي للأكبر lymph capillaries, pre-collector, lymphatic collectors, and then we have the major ducts and trunks, and then the major venous circulation. Okay, just before reaching the heart behind the clavicles أو عند الأنجولس فينوسز هناك بيصبوا عندي thoracic ducts. الأنجولس فينوسز اللي هي ما بين السبكليفيان اللي هو زي ما هون بأشر والinternal jugular vein. This is where the lymph circulation ends. Composition of the lymph. Now the lymph تعريفه إنه هو clear, transparent or yellowish alkaline fluid, slightly less viscous than the blood. Now when this lymph is filled with the absorbed fat of the digestion in the intestine, it becomes whitish and viscous and it's called chyle. The composition of lymph. Lymph مكون من water, proteins, lipids, carbs, enzymes, urea, minerals, hormones. It has toxins, bacteria, body waste, cells, and some dissolved gases like CO2. 75 to 100 gram proteins per day escape from the blood circulation. This is about 50% of the protein circulating in the blood plasma per day. Now these protein زي ما حكينا transported into the lymphatic vessels. Lymph production are 2.1 to 3 liters per day. The lymphatic circulation is a one-way structure beginning with the lymph capillary. Now the lymph capillary بتتميز إنه ما فيها valves. Have no valves in their central endothelial channel. يعني عندنا النيوترينز بتفوت فيها عن طريق pinocytosis and micropinocytosis زي ما احنا هون شايفين بالصورة. The anchoring filaments. الانكورينج filaments اللي هم هدول رقم 2. Now, anchoring filaments help the lymph capillaries to open widely if there is significant fluid pressure in the connective tissue. It helps when the tissue is moved manually by lymph drainage therapy or similar lymphatic therapy. يعني الانكر فيلامنت اللي هي بتوسع عندي الليمف vessels لما بيزيد الليمف pressure عشان الليمف flow easily. The precollectors, it has one-way valves spaced about every 2 to 3 millimeter. These valves help to prevent backflow and to move lymph in one direction to the big collectors. تمام. Now these valves are essentially invagination of the lymph vessels. يعني من نفس lymph vessels they are invaginated to حتى يكون عندي هذا الvalve, and it consists of 2 leaflets, so it's called bicuspid valves. The lymph collectors. Now the lymph collectors are the main transporting vessels of the lymphatic system. They are large valves and it has muscular units which carry the lymph to the surrounding lymph nodes. Consist of 3 layers: intima, media, adventitia. The bicuspid valve is found at each end of the lymphangiones or at specific intervalvular units of the lymph collectors. Lymphangiones give the lymphatic vessels the characteristic appearance of a pearl-like necklace زي ما احنا شايفين هنا. Now the lymphangiones are considered the functional unit of the lymphatic system. في النهاية بنتهي عندي lymphatic system trunks and ducts, and they are the biggest lymph collectors of the body. They carry lymph to the terminal pathway زي ما حكينا للdeep venous system عند الأنجولس فينوسس اللي هي حكينا ما بين الinternal jugular وما بين السبكليفيان. وparticularly احنا بنحكي هون عن the thoracic duct. It's the largest lymphatic vessels in the body. وهيك بنكون خلصنا المقدمة.
Okay, so now we're going to talk about the lymph trunks and the ducts. As we know, the lymph trunks and ducts are the biggest lymph collections in the body, and they carry the lymph to the terminal pathways in the deep venous system at the base of the neck. In particular, the thoracic duct is the largest lymphatic vessel in the body. The functions of the lymph nodes. First of all, they are biological filtration. Specific immune cells destroys foreign or unwanted substances, which can be then handled by the liver, and the elimination of the urinary tract, digestive system, skin, and lungs. Immunological. They provide an environment for capturing and destroying microbes through phagocytosis and other processes. Lymphocyte production and maturation as well. Also, lymph circulation is divided into three main types: superficial circulation, deep circulation, and very deep circulation. Superficial circulation is just under the dermoepidermal junction. It accounts for about 70% of upper limb lymph flow. It's not directly stimulated by exercise. But the deep circulation of the muscles is below the fascia, but the very deep circulation of the viscera, which is stimulated by muscle contraction. So to sum up, the superficial circulation is not stimulated by exercise, in contrast to the very deep circulation. Physiology of the lymph nodes: 80 to 90% of fluid is filtered into the interstitium from the capillaries, is reabsorbed into the venous side. The remaining 10 to 20% of the fluid and protein is removed from the interstitium by the lymphatic vessels, as we can see in the picture. Any condition that increases the capillary pressure, interstitial fluid, proteins, or capillary permeability, or decreases the plasma colloid osmotic pressure alters the equilibrium, as we know, the Starling equilibrium. This causes the fluid movement out of the arterial capillaries and into the interstitium. The pathophysiology of the lymphedema: occlusion or damage to either side of the venous side of the capillaries or to the lymphatic system may decrease the reabsorption or lymphatic vessel drainage of the fluid and protein, causing the lymphedema. This is a picture of primary lymphedema, which is the following. Lymphatic vessels or nodes are either absent, aplastic, underdeveloped, hypoplastic, or too large and incompetent, hyperplastic. It's more common in women, being 70 to 90% of cases. The earlier it appears, the worse the prognosis. It is characterized by non-pitting edema as well. Kinmon's age classifications: lymphedema, congenital, and hereditary. Lymphedema type 1, as known as Milroy's syndrome. Hereditary lymphedema represents only 1 to 2% of the primary lymphedema. Lymphedema presents at birth. Congenital accounts for 15% of the primary lymphedema. Type 1 also is autosomal dominant. It's more common than the recessive form, usually bilateral in the lower limbs. Type 2, which is called Meiggs syndrome or Meigs syndrome, 75 to 80% of primary lymphedema. Its onset is at puberty. Usually results of lymphatic hypoplasia, not aplasia, not hyperplasia. Also affects the distal lymphatics of one or both legs. Lymphedema tardum is also a primary lymphedema. It's similar to lymphedema praecox. The only difference is that it appears after the age of 35, not at puberty. Now we'll talk about secondary lymphedema, which is due to surgery, biopsy, dissection, or radiation. Numerous surgical interventions, especially for cancer, involve the removal of lymph nodes or their destruction by the radiation therapy, causing fibrosis. Lymph vessels can regenerate after being cut, but it can be inhibited by the formation of scar tissue. Also, metastatic carcinomas can cause obstruction of the lymphatic system. Trauma, burns, physically destroy the lymphatic vessels and nodes and provoke local or regional lymphedema, at least temporarily. Filariasis, endemic lymphedema, elephantiasis, involving the infection of the parasitic nematoids or worms of the order Filaroida.
يعطيكم العافية. معكم زميلكم إبراهيم عربيات. اليوم بدي أشرح لكم عن الليمفedema. أول شيء بنشرح آخر موضوع بالسكندري lymphdema اللي هو lipolymphedema. Lipedema begins as a pathological accumulation of fat in which lymphatic circulation is normal. Later, lipedema can develop into a lymphostatic edema called lipolymphedema. The mechanism is compression of the lymph vessels by the adipose layer. عندنا صورة لللايبوليمفيديما أو اللايبيديما. There is بسرعة comparison بين الموضوعين الليمفيديما واللايبيديما. Lipedema symmetric, painful, asymmetric, painless. There is hematomas, no hematomas, no erysipelas. Erysipelas, frequent erysipelas is inflammation of the upper layer of the skin, while cellulitis is infection of the lower part of the skin. There is no foot edema in here. There is foot edema. Stemmer sign is negative, stemmer sign positive. We'll talk about it later. Conditions related to lymphedema: cardiovascular syndrome, cholestasis edema syndrome, Norwegian type, Cumming syndrome, Hennekam syndrome, Klippel-Trenaunay syndrome, lymphedema distichiasis syndrome, Noonan syndrome, rheumatoid disease, or Turner syndrome. Breast carcinoma lymphoid incidence. Lumpectomy with sentinel node technique has a 2% risk for developing lymphedema. How do we pinpoint sentinel node during surgery? We inject the surrounding tumor tissue with radioisotope and visualize the lymph nodes uptake at the axillary region. During surgery, we inject blue dye and remove these nodes, or inject positive for the blue dye in the axillary area. Then the lymphedema is considered chronic after 3 months. If the patient persists with a difference of 2 to 3 centimeter in circumference or 10% volume difference between the affected and unaffected limb for more than 6 weeks after surgery. Malaise, discomfort, tightness or skin tension, heaviness, heat, pain affecting the skin or articulation, numbness and paresthesia. Other signs associated with swelling: there's fibrosis, which is thickening and dryness of the skin, hyperkeratosis, papillomas, decreased range of motion in the affected joint or limb, stiffness in the affected limb, or contractures of the joints. Stemmer sign: it reflects the degree of distal fibrosis, usually making it an especially accurate indicator for primary lymphedema of the lower extremity. What is stemmer sign? It's the skin fold at the base of the toe in the lymphadematous limb. The sign is positive in 82 to 92 of primary lower limb lymphedemas and in 56 of cases of secondary lower limb lymphedema. Special diagnostic tools like imaging. These are generally used for difficult diagnosis to help assess whether the patient is suffering from a pure lymphedema, veno or fibrillo lymphedema, lipolymphedema, lymphedema secondary to an arterial condition, angiodysplasia, etc. There's a test called lymphoscintigraphy. It's the gold standard for diagnosis and follow-up of lymphedema. TC999 colloid is injected between the digits of the foot, and the radiotracer distributes along the lymphatic system, yields more functional than anatomical information. There is an image of the test. Here we have the two limbs, the left limb and the right limb. Here we have the calf area, the thigh area, the pelvic area, and the liver and the kidneys. On the right, we have normal reuptake or distribution of the radioisotope tracer. On the left, there is impaired uptake of it. There is reduced radioactivity in the lymph collectors on the left side, which is of course abnormal. Here we have the results of the test, the arrival time, the lymph node uptake 20 minutes, 22 on the right, 1.9 at the left. CT provides more anatomical than functional information. Specific images in lymphedema: enlargement of the skin, subcutaneous tissue is heterogeneous, lymphatic lakes, muscle compartment. Here we have a CT of the right limb. There is a chronic lymphedema stage 2, marked thickening of the skin and reticular subcutaneous structure formed by increased fibrous tissue and fluid. MRI, there is diffuse and dermal and subcutaneous edema. Thickness between fat lobules is increased. The fat cells is isolated by fibrosis, intralobular fibrosis. There is specific honeycomb aspect of the subcutaneous compartment, increased size of the subcutaneous fat compartment. Consider arterial and venous duplex if a deep venous thrombosis or arterial insufficiency is suspected. Thank you.
مرحبا، معكم شهم البني وراح أشرحكم بقية موضوع الليمفedema. بالبداية خلونا نحكي عن differential diagnosis للليمفedema. ممكن يكون elevated pulmonary artery pressure أو congestive heart failure أو venous insufficiency أو use of non-steroidal anti-inflammatory drugs أو proteinuria أو idiopathic causes. رح نحكي عن ال stages of lymphedema. بالبداية في عنا 4 stages. stage 0 أو latent ممكن يكون mild lymphedema أو stage 1. هي بتكون still beating وبتكون أقل من 3 سنتيمتر larger than the opposite extremity. ممكن تكون moderate lymphedema أو stage 2 تكون non-beating وبيكون في difference حوالي 3 ل 5 سنتي. السيفير lymphedema أو stage 3 بيكون أكثر من 5 سنتي difference. نبلش بستيج 0. هي بتكون subclinical أو latent stage. صعب to be detected clinically. Microscopic examination usually reveals abnormally tortuous and dilated lymphatic vessels and widening of the subcutaneous spaces caused by increased pressure in lymphatic capillaries. Stage 1 lymphedema بتكون عادة reversible. السويلنج عادة بيروح لحاله. بتكون beating soft edema high protein edema وfocal fibrosclerotic tissue alterations. هاي صورة عنها. Stage 2 lymphedema بتكون spontaneously بس بتكون irreversible. The skin does not move much and is chronically inflamed. Fibroblasts predominate in the stagnant وprotein rich liquid. The skin becomes thickened developing hyperkeratosis. طبعا هذا الكونديشن does not resolve مثل ما reverse مثل ما حكينا لحاله. can usually be reduced through CDD. وهاي صورة عنها. Stage 3 أو elephantiasis بتكون non-beating very hard edema with no skin movement, significant fibrosis and hardening of the skin, proliferation of adipose tissue, lymphostatic varicose papilloma formation and skin fissuring, significant loss of joint mobility and movement. هاي الصورة للإلفنتيسز. نلاحظ كيف تكون مطابقة لكل الصفات اللي حكيناها. الكومبليكيشنز عادة بصير عندنا شيء بنسميه lymphangitis. patient بيكون جاي بإريثيما increased swelling مع color وفيفر وتشيلز. نتعامل معها كأنها emergency. oral أو IV antibiotics. إذا كان في skin laceration added topical antibiotics. lymphangiosarcoma كمان ممكن تصير عنا والستيوارت تريفيرس سيندروم. الكومبليكيشنز كمان ممكن يصير عنا infection أو inflammation. ممكن تعمل لي damage للليمفاتيك سيستم وتعمل لي lymphedema. Infection is often difficult to treat because of lymphostasis and may cause fibrosis, which further compromises the lymphatic drainage system. Absolute contraindications for decongestive therapy. إذا كان في hemorrhage أو bleeding. إذا كان في acute enuresis أو renal failure. إذا كان في carcinomatous invasion of the extremity. No large scientific studies have shown any increase in metastasis in cancer patients treated with lymphatic drainage. Sensory impairment, brachial or lumbosacral plexus injury. Acute infection, fever, early inflammatory disease, co-education with chronic tuberculosis or toxoplasmosis which can be reactivated and become acute. Serious circulatory problems, venous thrombosis, risk of embolism and peripheral arterial insufficiency. Major cardiac conditions, unstable angina pectoris, acute myocardial infarction and uncompensated congestive heart failure. Major cardiac conditions. طبعا بهي الحالة it's not recommended to work on cardiac edemas if the cardiac problem is not under control due to additional liquid coming from the tissue drainage increasing the cardiac preload. This arises a degree of uncertainty in respect to patients with compensated congestive heart failure and a severe left ventricular dysfunction إذا كان ejection fraction أقل من 30%. طبعا work close with physician. شكرا.